All right, this is one of our first lectures in 2400, just kind of setting the stage for health behavior theory, what it is, why it's important, how we use it, those sorts of things. Very fundamental and introductory. So when I say theory, or when you hear me talking about theory in this course, theory or model sometimes will be used interchangeably. So just keep that in mind. So one of the first theories we'll talk about is actually called the health belief model. It is a theory. Some of the other theories that we talk about would be things like the trans-theoretical model. So again, we have that word model in there, but it's actually a behavioral theory. And then we have other things that we're going to talk about in this course, like the theory of reason, action, and planned behavior, social cognitive theory, etc. So just right up front, I want to make sure you understand that when you hear theory or model, those terms are used interchangeably for the purposes of this course. Now, to throw a monkey wrench in that, we're also going to talk about something called the social ecological model in a separate lecture. And that is actually not a theory, it's a framework. And so, these terms that we're using can be a little bit tricky, can be a little bit confusing, but I'll make those points along the way to be sure that you understand that. So what is theory? A textbook definition would be that theory is a set of interrelated concepts. What we mean by this is definitions and propositions that present in a systematic view events or situations by specifying relations among variables. And so one of the things that you're going to see when we look at theory, when we look at an image of theory and the components of theory, you're going to see these boxes and arrows, and that's what we mean by specifying relations among variables. The purpose of theory is to explain and or predict behavior. That is our reason for using theory. Theory comes in very handy when we're interested in doing behavioral research, because if you think about it, there's any number of things that we could measure if we want to understand what are the factors that predict and explain a particular type of behavior. So just to give you an example, if we're interested in something like healthy eating or physical activity, some type of health promoting behavior, we might think about a person's confidence in their ability to engage in physical activity, to find places to be physically active, to find places that offer food choices that they can purchase that would allow them to eat a healthy diet. Also aspects of the world outside the person, including social support, access and availability to places to be active, and places to buy healthy food, these sorts of things. So there's a lot of different things that we could measure. But if we just go out and measure a bunch of things, then we don't have a systematic or very smart way of going about what we're doing. And so theory actually takes what we know in terms of factors that seem to be strongly related to these behaviors from previous studies, and it puts all those things together in a very strategic and systematic way. And that is one of the ways in which our theories and models that we discuss in this course were put together or developed over time. And keep in mind too, that theories and models evolve over time. And so when behavioral scientists create a theory, a lot of times they have to throw away some of the pieces that don't work well, some of the constructs that don't work well, and they have to add some that contribute to the theory in a way that it does a better job of predicting and explaining behavior. So that is a natural thing that occurs with the development of theory over time. One of the fundamental ideas in terms of theory is that if you have a good theory, it's broadly applicable. And so what that means is that although health behavior theories are usually developed for a specific purpose, like health belief model was developed specifically to look at why people were not using free screening opportunities to test them for tuberculosis back in the 1950s and 60s. There are other models and theories that were developed looking specifically at sexual behavior, looking specifically at smoking behavior, and we can go on and on. But if the theory is a good, robust theory, it will also work for other behaviors. So you can take, for example, trans-theoretical model, which was designed specifically to study cigarette smoking, and we can apply that to, and keep in mind that cigarette smoking is a risk-taking behavior. So we can apply that to other risk-taking behaviors like unprotected sex or something along those lines, even alcohol and drugs. But we can also apply that theory, if it's a good theory, if it's a robust theory, to health promoting behaviors. So things like eating healthy or being physically active, seeking screenings, those sorts of things. So theory helps provide a systematic way of assessing health problems and, again, understanding what predicts behavior. What are the factors that are related to behavior? If we know those things, we can manipulate those things in programs and interventions and actually get people to change their behavior in a positive way. Or we can get them to stop engaging in risk-taking behavior or unhealthy behaviors. Two different ways, two different sides of the coin, if you will. The theory is also important because the constructs also tell us specifically what we should be measuring. So if we truly want to know if a set of factors that are arranged in a particular way, which I'll show you in just a minute with a figure of some of the theories we're going to talk about in this course, we can use that to quantitatively assess whether or not these factors are predicting behavior and how, if at all, they are related to one another. At the same time, we can use such measurement to understand when we apply these theoretical constructs in our programs and our interventions, if we're seeing changes in those things. If we see changes in those things, for example, if someone's self-efficacy is increased as a result of a program or intervention, we should be able to measure that. We can capture that and measure it, let's say with a pre-test and a post-test. But we should also see a correlating change in actual behavior. So if their self-efficacy is going up, and if it truly is related to that behavior that we're studying, then we should see that change in our measurement. So theories then give us some direction and structure for understanding human behavior and developing programs and interventions and determining what to measure and evaluate in our programs and interventions. So theories can provide answers to program developers' questions regarding why people aren't engaging in a desirable behavior of interest, how to go about changing their behaviors, and what factors to look at when evaluating a program's focus. That is a nice summary of what I just said. Theories also, again, giving a structure, help us to determine what to focus on and help us discover important factors that are related to particular behaviors of interest. In doing this, we can gain considerable insight into what we need to be working on in our programs and interventions and how to tailor those interventions to change behaviors in a healthy way. It also guides us in determining what we should be monitoring on a consistent basis or an ongoing basis. So once you have an established theory or a model, you know exactly what you need to be measuring and monitoring in terms of surveillance over time. And so, again, theory provides us with a structure. If we know that some collection of factors are related to one another, these constructs that we're interested in, that will guide us in telling us what we need to be measuring and what we need to be trying to impact in terms of getting people to change their behavior. So the idea then is, if we can increase self-efficacy, which is your confidence in your ability to engage in a certain behavior, if there are things that we can do in a program or intervention related to improving or increasing self-efficacy, once again, as I said before, we should see a correlating change in a positive way in a particular health behavior. Some other constructs that we talk about would be things like goal setting, overcoming obstacles, and things that get in your way in terms of being consistent with making healthy choices. And we can measure these things. We can apply these concepts in very concrete ways in programs and interventions. So there's specific educational and behavioral components that we would use in our programs and interventions to impact these things, change these things, and ultimately that's going to lead to behavior change. So, as a reminder, theories and models that we discuss in this course help us to explain behavior. So, what are the things that influence a behavior? What are the things that lead up to behavior? So, when it comes to, for example, some of the unhealthy behaviors or risk taking behaviors like unprotected sex, um, drinking, using drugs, smoking cigarettes, we know that there are knowledge factors, attitudes, and beliefs that are related to engaging in those behaviors. But there's also social influences. So things outside the person, these interpersonal relationships, social expectations, social norms, these sorts of things. So we can have any number of constructs or any combination of constructs in a theory, but these theories and models were developed in a particular way based on what was known about that behavior from other studies. So the researchers that developed the theories and models that we talk about in this course had previously collected data that indicated to them that certain factors were strongly correlated or associated with the behaviors that they were studying. Or maybe they used qualitative data collection, and through discussions with participants in their studies, the participants would say things that would tell the researchers that, or we give them insights into things that are important, things that the person thinks about or considers, or that they will even directly say, this influenced me in my decision, or this strong pull that I feel from expectations from others in terms of social norms, even though they may not use the word social norms, but just describing that there's some social influence that leads them to smoke or to drink or to use drugs, for example. Um, then that qualitative description can be used by the researchers to hone in on exactly what construct that might be. And they can develop ways of measuring that, and they can develop ways of using that information to guide their programs and interventions to either prevent unhealthy behaviors or to promote healthy behaviors. So, health belief model is one of the models that we'll talk about, one of the theories, even though it's called a model. One of the theories we'll talk about in this course, and the health belief model is focused mainly on a person's beliefs. And I want to point out the specific beliefs. Under individual perceptions over here, you've got perceived susceptibility to disease and perceived seriousness or severity of disease. Each of these are two distinct beliefs that a person may hold. So, one way of thinking about perceived susceptibility would simply be I might ask the question or have some thought or belief about whether or not I could contract a particular disease. Maybe COVID would be a good example, since that's an infectious disease. And there are people who believe they are well protected. They don't need to worry about that. And then there are people on the other end of the spectrum who believe that they could get it from anywhere, and they're very fearful of that. And so there's a wide range of beliefs. A lot of people fall in between those two extremes. Another belief has to do with the perceived seriousness of the disease. And this is a separate issue from susceptibility. Susceptibility has to do with whether or not I believe it could happen to me. Perceived seriousness has to do with if this were to happen to me, would it be a big deal? So, is COVID actually life threatening? Is it something I should be concerned about or not? And again, people are on different extremes with this. A lot of people are somewhere in between there. So you can be high on susceptibility, but then believe that it's not very serious. So there's a very low death rate. I'm young and healthy. And so um, the one belief sort of counteracts the other belief, if you will. Now, if we look over here on the right hand side of this model, we'll see perceived benefits and perceived barriers. So these constructs have to do with a person's perceptions of the good things that will occur if I do some, if I engage in some preventative behavior, let's say wearing a mask or washing hands, it could be any number of things. Um, Perceived barriers have to do with whether or not it would be difficult to engage in preventive behaviors or actions. So, even something as simple as wearing a mask all day is very uncomfortable. There's not a problem with getting a mask or actually wearing a mask, but wearing it for long periods of time, I just don't want to do that because it's very uncomfortable. I can't breathe. I'm claustrophobic, what have you. That could be a barrier. Another barrier could be simply not being able to get a mask to protect yourself, but that is not a real issue, at least in the part of the world where we live. So those are the four main belief components of health belief model. We've got some other factors here. We've got demographic variables. So um, there are any number of demographic variables that are related to our perceived threat of risk of disease. If we're older, we may believe that we're automatically at greater risk. If we're younger, we may be a little more cavalier about the idea of extracting such a disease. And then we have these external factors that are referred to as cues to action. So these are things outside the person. Could be something that a family member or friend says to you, could be advice that's given to you by a healthcare provider. It could be something that you learn about in the news or on social media. And these are external factors. So we're going to go into this model in greater detail, but this is just a brief introduction of what a collection of constructs look like with the boxes and arrows that show the relationship between these different constructs. Notice that everything ultimately points to the likelihood of taking recommended preventive health action, or depending on what you're studying with health belief model, this might just be the behavior itself. So it might be um, smoking, it might be engaging in physical activity, it might be reducing dietary fat intake. Could be any number of things, but the behavior would go in this box to the far right down bottom here. So change theory is another word that you'll see planning models and logic models. So change theory has to do not so much with behavioral theories and models, but a bigger idea of what a health promotion program or intervention looks like and how things work together. So within change theory, we may see behavioral theory and models embedded within this idea of change theory. And so let's look at some examples. So the generalized model for program intervention, and you're going to cover this in great detail in Health 3400. This is the general model for developing, implementing, and evaluating health promotion programs and interventions. And then there are variations of this. So uh, at the most basic level, you do some sort of needs assessment, and that's where you get information from the literature, from the kinds of people that you would serve with your program, intervention, et cetera, maybe some clinical knowledge. You set goals and objectives, you develop an intervention related to all that, you implement, and then you evaluate. This is the general model for health program planning, implementation, and evaluation. Now, there are specific models for planning, implementing, and evaluating. They were developed for specific reasons. For example, there is one that's developed looking at school health promotion. There are models that are developed looking at more of a community base, like out in the real world, um, broader context. And so those just take these main ideas and concepts that we have here, and they are further refined to be more specific to where your program or intervention would actually be executed. Precede proceed is an example of a more complicated planning model. So notice that the phases go from right to left across the top here, and then left to right across the bottom. So the social diagnosis has to do with what is the burden of the disease or condition that you're interested in. We tie that to actual data that we get from our epidemiological studies. And from that, we determine the behavioral, environmental, educational, organizational, and policy factors that are important related to going all the way back to social diagnosis here, the health problem that we're studying. Once we go through all those phases and we understand all of that, then we can develop and implement and evaluate our programs and interventions. So this is an example of a planning model, which is used to take you step by step through planning, implementing, and evaluating programs and interventions. We won't go too deep into that. That's really more Health 3400 kind of stuff, but it's important for you to understand that now. And so if I go back to this slide, once we do all this planning and implementation, we can plug in theory and model to each one of these. So our theories and models guide us in what we should be measuring, what we should be trying to manipulate or change to lead to changes in behavior, and we plug that into this structure. That's one way of thinking about that. So that's a planning model. Next, we have a logic model. So a logic model represents all the things that you're doing in your program or intervention kind of all in one place. And so we think about logic models as working backwards. So you've got some goals, maybe one goal or multiple goals that you want to accomplish as a result of your program or intervention. That might be to reduce teen pregnancy, to increase physical activity among school age children. It could be any number of things. There will be one or more objectives that are going to lead you to that ultimate goal. And your objectives have to be smart, specific, measurable, attainable, realistic, and time sensitive. Again, these are things that you take a deeper dive into when you take the Health 3400 course. And there are certain activities that you would be doing, one or multiple, to lead you to each one of those objectives that will ultimately lead you to the goal or goals that you want to accomplish. Now, there's certain people, equipment, supplies, etc. There's certain types of resources that you need to complete those activities that will lead you to accomplishing those objectives and ultimately reaching the goal or goals that you've set. So this is an example of a logic model. So the reason why I'm sharing this with you is because you're going to see theory, you're going to see model, you're going to see behavior theory, behavior model. You're going to maybe see the term change theory, planning models, logic models. All of these terms are in our lexicon or in our vocabulary in public health and health promotion in particular. And they all mean different things and they all work together in some way. This is, again, a big picture discussion just to give you some broader context. And what we're going to do is we're going to circle back into and focus back down on some specific behavioral theories. This is an example of a logic model. This is so in this slide we're looking at sort of a generic framework for what a logic model might look like, and then here we have a logic model that's actually got real concrete stuff in there. So the impact or outcome or goal that is trying to be reached in this particular logic model is decreasing blood pressure. The behaviors that would lead to that include following the DASH diet, which is a blood pressure reducing diet that's evidence based, and also increasing physical activity. But before you can change physical activity and healthy eating, there are certain factors that these are the things that we're really talking about in this course: knowledge, interest, attitudes, beliefs, all these sorts of things, skills, all of these things that we see in this column and in this box are what we extract from our theories and we plug into programs and interventions. So this is where theory lives, right here. So what we know about specific theories, and if we want to change change behaviors to be more healthy with respect to eating and physical activity, making better choices, then there are certain theories or models that work well with doing that. And so we would just plug in those components here. If we work backwards from there, there's certain things that have to happen at the organizational level to set all of this up moving forward. And there's certain activities and resources that we would need to do all of these things. And so that's just all represented here, all in one place, which is kind of neat and tidy. This is an example of, we looked at the generalized health promotion planning, implementation, and evaluation model. This is a more specific one that is developed for community health activities. It's called MAP. And I don't want to get into this because that's really 3400 material, but I just want to circle back and make sure that you understand that we do have more specific planning models that guide us in our planning, implementation, and evaluation in the real world, especially in public health practice, not so much research, but public health practice. So good theory then is generalizable and it's testable. Theory or the models that we talk about in this course serve as a bridge between medicine and public health. So I want to focus here on this slide on the ideas of concepts, constructs, and variables. So a concept is a primary element of theories or models that we're talking about. These are the building blocks of theory, if you will. So beliefs would be an example. Now, there are specific types of beliefs. So when we get into specific types, then we're talking about a construct. So expectations and expectancies are two specific types of beliefs that we talk about in social cognitive theory. And so that differentiates the broader idea of a concept with the more specific idea of a construct. So a construct is a specific type of concept. And then ultimately we have a variable. So a variable is something that we have measured that we can use in data analysis. And so we measure these specific constructs in certain ways, and then we can use that in our data analysis or evaluation. So here's an example of a scale that we would use for evaluating self-efficacy. So you have a series of statements here. I can arrange, or you can arrange transportation to get a mammogram. I can find a way to pay for a mammogram, etc. You would answer this on some type of agreement scale. And let's say that ranges from 1 to 5, where one is low agreement or no agreement at all, might be strongly disagree. The 2 response would be disagree. Maybe the 3 response would be neutral. The 4 response would be agree, and the 5 response would be strongly agree. So that scale would, the response options for each one of these statements would range from 1 to 5, representing somewhere between strongly disagree to strongly agree. The higher number representing greater agreement, the lower number representing less or no agreement, or even a negative agreement. So we can see some information here on this slide, the mean for each one of the items, the standard deviation, corrected item total, and the alpha. This is, again, putting things in context for you. So there's a statistic called Cronbach's alpha, and the closer that is to 1, the better the overall scale is. But what we can see here in this far right column is how the overall alpha, or Cronbach's alpha, the so the overall alpha down bottom here is actually 0.87. But you can see that if we removed any of these items, the alpha is going to go down, and we don't want that to happen. So what that tells us is that if the overall alpha is 0.87, and if we remove any of these items, the overall alpha decreases, then we should not delete any of those items. Now, if we were to see numbers in this far right column that are 0.9 and above, then we might consider deleting some of these items in our scale. So this is a scale development kind of example. And so you know where these things come from and how they're developed. So we use these types of scales to measure the constructs that we're talking about. So when you select theories for application, you want to think about what was the theory or model originally developed for? Who was it used with? Because that tells you if, whether or not you can use that with children or adults, depending on what your target population is. If it has been developed and tested and used in that population, then you should be able to use it. If not, then you're kind of plowing new ground. Doesn't necessarily mean that you can't use it with a different population, but you have to understand that your research questions, one of the primary questions would be, does this theory even work with children, even though it was developed with adults, and that sort of thing. So always consider what the theory was originally developed for and who it was developed for. So theory, constructs, and these boxes and arrows should be logical, consistent with what we know clinically and what we understand about the behaviors that we're studying, and that information should be validated by past research. Good theory should provide a systematic description of the relationship between these factors or constructs or determinants that we're talking about and the health behavior, should specify the importance of these factors. So some factors are stronger than others, but they all work together, and provide guidance on um, how we can utilize this information, these constructs that we're measuring. So we've got some intervention that we expect to change a particular health behavior. And what happens in the middle there is what our theories or our models are explaining and predicting. So that's a visualization of the real application. So when you're picking a theory for application, you want to make sure that the constructs relate in a meaningful way to the behavior that you're studying. Again, think about why a particular behavior theory or model was developed in the first place, and that tells you whether or not it could be used for what you're studying. If it hasn't been used for that particular behavior, again, then maybe you're plowing some new ground, and it makes sense logically that those constructs would be related to this other behavior or to some other population. And so that may be one of the reasons why you're actually going about doing that research or that programming. So theory, as we think about it here in the West, um, these theories and models really line up with the Western tradition of thinking about science in terms of the universe being ordered and regular. It's predictable. If we have information that, if we have constructs that work well together, that will be apparent in our study of some particular behavior that we're interested in studying. And so our constructs are going to relate well together and do a good job of explaining. And through this process, we can understand more and be able to do a better job of changing behaviors. Now, I'm going to skip through these fairly quickly. The health behavior theories and models that we use in public health that are public health specific are influenced by a number of fields. So, behavioral psychology, so the idea of classical conditioning and operant conditioning that you learn about in Psych 101, you'll see some aspects of that in some of the theories that we talk about, and I point that out along the way. Cognitive psychology is also influencing what we're studying because a lot of the things that we talk about have to do with a person's knowledge, things like decision making, um, these sorts of things. And so you're going to see some influence of cognitive psychology in the theories and models that we talk about as well. And then there's also some more fluffy constructs, if you will, along the way that we'll see that come from humanistic psychology. And then certainly a lot of social psychology influence, especially when we get to the theories where we're looking at interactions between people. And then some of the bigger, broader concepts and constructs that we look at would come from fields that look at things from, not so individually focused view, but more of a, higher level view of looking at entire populations and the influence of things like culture and religion, et cetera. So that's where also fields like cultural anthropology come into play. So what we understand about the differences in cultural beliefs that different kinds of people have and different population groups have, those are really, really um, interesting things to look at in terms of understanding whether or not our standard theories and models work well when you study people who have different backgrounds and different cultural beliefs and worldviews. And then, of course, the really big picture, ecological systems in particular, we're going to talk about that in more detail when we get to the social ecological model, which again is not a model or theory as we talk about it really in this course. It's a framework, but this idea that there are multiple systems that influence us that are at play that also interrelate with one another. These are kind of esoteric ideas and concepts and discussions that we have, but they'll make more sense as we move forward. So this slide just shows you a list of the most common theories that we have in public health, gives you some idea of when they were developed, how long they've been around, that sort of thing. And then lastly, it's important to think about when you're reading a study that utilizes a health behavior theory or model, you want to understand, is that study informed by theory? Does it apply theory? Is it testing theory? Or is it building or creating theory? So, building or creating theory would be like working from scratch, or um, maybe even some of the evolution of theory that we'll talk about along the way, where constructs are added or deleted. Testing theory is where we take a theory or model that we believe to work very well, and we actually go out and collect data with it through these scales that we've looked at here today as a quick example. And we want to know if these constructs actually do predict and explain behavior and how they relate to one another. And then applied theory is where someone may not fully use a theory or model as we know it. They may use some components, and that happens quite often. It's not the most ideal thing, but informed by theory would be the higher level where um, um, there are issues with the application of theory comes into play. So, just to wrap things up here, theory, research, and practice are a continuum along which the skilled professional should move with ease. These are quotes from one of my favorite health behavior scientists. And then Karen Glanz, another quote from her: the best theory is informed by practice, and the best practice should be grounded in theory. So her quotes are just sort of reiterating for us that we should um, take theory and model very seriously in our research and in our practice. And we should be very vigilant in how we go about using these so that we can do better work and ultimately advance the field.